the weekends. And it's days, extra days. Nobody's in groups anymore. Okay, Cameron, you're the representative. And unless you at all seek it. So let's go over these together. And here are the rankings for what we have. What I said, most creative. Who's team 4? Okay, yeah, team 4. I thought the Barry Bonds, Mark McGuire thing, the comparative analysis, was really good. He had to break down 2 different cases, and they were both really close. And I thought Ben Button was a nice idea of the inverse. So that was the runner-up, was Benjamin Button, and the most creative. That in the hardest case, I just put it in order. And I went through just one page at a time. So I had all of them open to page 1, and then I just sort of wrote all over it. All of them open to page 2, wrote all over it. All of them open to page 3. And at the end, I did a summation of the scores, the mean score of everything. But the Thierry Lannister one, that was the hardest. And Benjamin Button was the most friendly. And he was creative for the 2 most friendly. So maybe as I was doing it myself, as I sat down, and I'm getting to some of the conversions, and I'm getting frustrated. Like, this is not creative. I was getting frustrated. So trying to do conversions. And then the least stumped, though, team 3 followed by team 2. We're the least stumped. And so those are all the points. I'll show you the team scores overall in just a second. But let's go through the 5 cases together. So we can just be on the same page for when this comes up on tests, when we're doing case studies on a test. So Miranda Bailey, successful surgeon, chief of surgery at Gray Sloan Memorial Hospital in Seattle. She's 52, stands at about 152.4 centimeters tall, and 12 point whatever stone. So I calculated BMI of 33. I think people got that. If you didn't, then I got my math wrong. Do we get BMI for her? That's one of the risk factors? Yeah. Okay. Her mother died, heart disease, at 54. So she had like a AMI, acute myocardial infarction at 54. So I put family history. Do you guys have BMI and family history? Mm-hmm. And she herself, Miranda, had a heart attack already. So she's high risk. Right? We're dealing with a high risk person. And one of the teams, the team that came in first, the least up team, did both exercises where it was stratification by signs, symptoms, and diagnoses. So if you have a diagnosis of something, is that something manifesting in signs and symptoms? They did that part and the risk factors. And so this would be not a risk factor, the heart attack, but it would be in that diagnostic history, signs, symptoms part of analysis. And then the other ones I got were that BP is 145/90, and her fasting blood glucose is 130. She seems to be a very stressed person. Miranda Bailey, right? She had a heart attack, and she's like a general surgeon. So sleepless nights. If you work in the hospital, there's very little sleep schedule that's acknowledged. And so fasting blood glucose of 130, we're getting into diabetic territory, right? So this is we're talking diabetes here, but a bunch of if you just get a bunch of cortisol, a bunch of stress-induced cortisol, and you can elevate your blood sugar in the morning. Same thing with just a lack of sleep. Your blood sugar is going to be elevated in the morning. And so I would have that be retaken if I were her a couple of times. But diabetes, she had a heart attack, and Miranda's intermittent claudication while patrolling the hospital has appeared clearly in Richard's mind, anxious Richard. So There's a few signs, symptoms, things that are elevated in terms of the risk class that she's going to be in. Otherwise, BMI 33, family history. She's taking statins, isn't she? So she's on a statin, and I kind of don't care what her lipids look like. If she's taking a statin, you just say risk. Like, yeah, but my statins, my lipids, my HDL, my LDL looks great. Yeah, with drugs it looks good. It's controlled with drugs, but you still count that as a risk factor. There's a lot that goes into this. The early research was just looking at, yes, we can cure, we can restore a healthy lipid profile with the use of statins, but what's the difference between the statin group and the placebo group in mortality? Well, there isn't one, but the lipids are good, right? And so we still count that as a risk, even if the lipids are good. And she's on a beta blocker and still has 145/90 blood pressure. So yeah, so she's going to be a very high risk person. 5 risk factors with potentially diabetes, a history of AMI, and intermittent claudication presently. So she's very high risk. Okay, so Benjamin Button, the second one. With a lifespan of 70, he is currently 25 years old, but we're all familiar with the story, Benjamin Button. So, yeah, aging backwards, he's like much older here. He's like 55 here, 45. He's 45. So he's aging backwards. So he's 45. So he hits that cutoff. He hits that limit by his pant size. His pant size is 43 inches, and so that would be the waist circumference. So it'd be a risk factor with his waist circumference. And probable secondhand smoke, but it's not certain here. So if you said secondhand smoke, yes, or if you left that one blank, that's fine. Either way, as long as you justify it. And his blood pressure is 135/82. So blood pressure would be another risk. We have age, we have BMI from the perspective of waist circumference, because it's waist circumference or BMI. Possibly secondhand smoke could be a third, blood pressure would be a fourth. And then if the cholesterol is a little bit tricky, and his total cholesterol is over 200 and his HDLs are over 60. HDL total was 212. And so we don't actually know because LDLs, because there's other types of, it's not, the LDL is not total cholesterol minus HDL. It's total cholesterol minus HDL minus IDLs and chylomicrons and stuff like that. So it's probably, we'll cancel out for cholesterol. That's what I did. It's not what you have to do, but that's what I did was cholesterol a positive and a negative. And so canceling it out. Total cholesterol is a little elevated, but the HDL's up there too. So age, waist circumference, blood pressure, and then maybe secondhand smoke. So 3 or 4 is what I got for Benjamin Button. Does anyone have any commentary on Benjamin? Okay, let's do the third one. Tyrion Lannister, he's 42, so not quite at that cutoff there. He's 1,342 centimeters tall. And so I think maybe it wasn't supposed to be centimeters, because that's like 43.5 feet tall. And Tyrion, who just watched Game of Thrones? Okay, so Tyrion Lannister is the little guy. So yeah, he's about 43.5 feet tall here in this one. And his weight is 68,892 grams. And so his body mass index, terrifyingly skeletal. What's the guy from is it Jack from Nightmare Before Christmas? Yeah, Jack, what's his name? Skellington, that's his last name? Okay, Jack Skellington. Jack Skellington probably has a BMI of 14 or 16 or something like that. I think Tyrion is less than 1. And so this is scary looking. He's really proud. So He walks a lot, right? 2.5 kilometers in mud, right? So we think that that's probably a little bit more. There's some intensity there. And 0.03 fornications takes a little while to add up to 1, but he gets there. And so I didn't put for sedentary behavior. I put he was fine. What did you guys put for sedentary? Okay, he's fine. He's getting a fair amount of movement, and you can go either way with that one. I didn't count it. But he has symptoms after bouts of drinking, such as passing out, syncope, swollen feet, edema, and a burning sensation within his chest, and dizziness. Those are 4 things. Now, he notes that relief is felt after belching loudly. I'm unaware of, I get that there's a burning sensation. Maybe the dizziness, maybe he's getting a little bit worked up over the burning sensation, he's feeling woozy or something, but ankle edema probably is unrelated to belching. And so that's something you would want to definitely check out, even if he's like, no, it's fine. Probably because he wants to go on drinking at the bottle rate that he has been. So I would be cautious with Tyrion. 8.3 pints of wine is quite a bit. But yeah, edema and syncope, maybe this is unrelated to belching. The glucose, 652, and it equates to about 130. So that is, again, very stressed, right? He's in wars. His dad is trying to kill him. He was like a prisoner. If you've seen Game of Thrones or read the book. So 130, that's something I would be very mindful of. Definitely risk factor, pre-diabetes risk factor, and maybe diabetes. But it could also be that he's in a period of very high stress and we just need to get him on a good day. And so getting some serial readings of that glucose. But if he has 130 for fasting glucose and ankle edema and bouts of syncope, Tyrion is not somebody I would want to put on an exercise program. I just say, like, make the fornications light and keep walking, I guess. Maybe back off of the wine, keep the jokes up. His blood pressure, 129 over 72. I think that's something like that. So he's close. The systolic is close, but it doesn't hit the cutoff. Systolic is close, doesn't hit the cutoff. For his total cholesterol, I got 172. And let me know if this is inaccurate. LDLs, 127 point something. HDLs, 42 point something. All right, so for the lipids, he's close. He's close with the HDLs. He's close to that 40 cutoff with the HDLs, close to that 130 cutoff with the LDLs. Not really that close to the 200 with the total cholesterol, but nothing there. I didn't get anything for the lipids, although it was close. Cigarettes, he doesn't seem to smoke. Family history, we don't know his mom, right? His mom died young, so we don't know her. So again, lots of stress that might explain the glucose. I got 1 or 2 risks, right? Age, fine. Family history, maybe. Cigarettes, fine. Sedentary, fine. BMI, very underweight. Despite waist circumference is close. I think his waist circumference was close to a cutoff, like 100 centimeters.
The risk factor is only the over, not like you
are. Yeah, it should be under 2. Yeah, I don't think, I think bones have a higher, just straight bones probably have a higher BMI than he has.
But it's not necessarily good.
But ACSM's cutoff, it's something to really note, because remember what that graph looks like. That graph is just a big U-shaped, like as BMI, right around 25, right, give or take, right at that entry level overweight. That's longevity. That's the lowest all-cause mortality risk. And then as BMI climbs, we risk things like diabetes, metabolic syndrome, cardiovascular disease, stuff like that. When BMI gets really low, it sort of just hits a wall and goes straight up where everybody dies. You can't get that low and hang on to life. And so he's below that life threshold. However, in quantifying people, this is just someone who's like, we're just at high risk. It's weird. So that's what I got, criteria.
What were them?
Lipids were close. Glucose was diabetic, but could be the stress. Waist circumference was also close despite his BMI. The bonds and McGuire comparison. I really like the narrative. That was a really nice narrative, introducing it in the first paragraph there. And then for bonds, I got age. I got that he's sedentary. He has a little bit of activity, but he's got not quite the amount required to graduate from sedentary. He smokes, not much, but he does a little bit. And if secondhand smoke counts, then this amount of smoke in his mouth directly counts. We don't know his glucose. His waist circumference counts. And where's HDL? And his HDL bring him down. So for bonds, I got age, sedentary, smokes, waist. So 4, maybe glucose, maybe, and then a minus with the HDL. So I have 3 or 4. With Mark McGuire, I got age, 57 years old. Glucose, his A1C was 8. I got probably family history. The arm thing, I doubt it's a problem, but he should get it checked out. Arms hurt for lots of reasons. It doesn't have to be some like coronary artery disease, sending pain down to the limbs. Arms, there's a lot of, Mark McGuire spent like half of his career injured. It's mostly back pain, I think, but for professional athletes have arm pain. I think that's probably fine. But to go get that arm checked out, probably family history, but definitely age and glucose. Did you guys get anything else for Mark McGuire? And the last one. Okay, so for this one, I got, this was the second hardest after Tyrion. Age was confusing. So I think I interpreted this right, where it's 2021 today. I think this case study was written in like the 1970s, and he was 11 at the time. So if it was 1979, he would still be 53 years old today. Is that right?
It was born on a lake.
That's what I thought it was, but everybody.
Okay, you fooled me. Okay. Okay. Yeah, that's
It makes him like 45, right?
Yeah.
okay. What is his what are we doing here? 0.1. You get a 10th of a bonus point for that. 0.114 for the complement at the start of class. Okay, 14 hundredths of a.
I subtracted. Yeah.
Let's set up newborn mid-1970s.
Okay.
Yeah,
It's clever. It's
2021 to 1975.
yeah. I was just confused. I think I spent like 10 minutes. I said, fuck it. He was born in 1979. That's what I'm writing down. So yeah, you fooled me. Let's see. So waist circumference is 102. So that would be a risk factor. Conservatively, if we're being as safe as possible and trying to really characterize risks where they may or may not be, family history seems a reasonable thing. Did he quit smoking less than 6 months ago? He quit smoking, right? He quit cold turkey to start to work out.
Yeah.
6 months, like precisely 6 months ago. Okay. Yeah, so smoking, realistically, smoking is probably not that much of a risk unless he was he really smoking hard earlier? They extinguished with a rush of a nicotine hit stuff. Okay, so heavy smokers and Quit 6 months ago, so reasonable to still count that. But yeah, you could go either way with smoking. And what did you guys? What did you have in mind for family history? Was that a yes or no from your perspective?
I think we had,
Okay.
we had the hop on the front trick, but that's great.
Okay. Okay. So, yes, this one should have been the hardest thing.
I thought if you go to other things, spend like 20 minutes on the finish first.
That's actually, yeah, you'd be the first one to finish by coming up with a really tricky one.
Do you have siblings, not counting them, they have half of the same?
I don't know, just ACSM has a very specific explanation for that stuff. And I sort of just ignore the really specific, even like with resistance or like physical activity, right? You're gonna do a bunch of physical activity. ACSM has the exact number of minutes of moderate intensity physical activity. I don't know, people are active or they're not active. It's not like that particular minute is of any importance. And using a sense of proportion about these things, like if you're talking about age, you know, and somebody is, well, my 45th birthday is tomorrow. Well, oh, good, you don't hear risky, you know. And so these cutoffs and the way you just have to characterize something. All right, what's a family member? Well, you know, my sister got married to. Okay, we're going to come up with a definition of family. But having a sort of a malleable approach is helpful in real life. On a test, it's kind of hard to be malleable because there's sort of like a right and a wrong, but if you can justify it, here's my thinking and the reason I did this, that probably stands up for it. So, and then with the lipids, all that stuff is really close. So the HbA1c, 5.65%. I guess that 0.65 you could round up to 5.7, but that's right under the cutoff for glucose. And then the HDLs, 1.56, 1.55 is the cutoff. So there's a lot of close stuff. There's right on that boundary, and apparently age as it's counted in calendar years. That's also on the boundary. So that one, I think I need to write down an answer for that. Conservative 4. You know, if you count smoking in family history, I could get 4 out of that, whatever. But I was counting age. So that was my breakdown. Do you have questions on any of them?
With when somebody has like a really high LDL, so that they're positive risk factor for that, the HDL is high as well. Still good.
Yeah, I just cancel them out. I mean, ACSM or some cardiologist somewhere might have something different to say about that. But the higher your HDLs are, the better it is, right? The higher your LDLs are, the worse it is. So, it starts to get a little bit problematic in some of these things because how many, randomized controlled trials or even epidemiological surveillance studies do we have where, okay, we're going to follow people, whose HDLs and LDLs are this profile. We're going to track them over time, and we're going to manage any confounding variables that might interrupt some of that relationship between cholesterol. And I'm unaware of data that have a nice, trustworthy answer for that stuff. So I just cancel them out, and I figure that's something close enough to the truth. Because again, remember, as we start talking about the heart, which we're done with, but you need an immune system profile, right? You need the blood pressure, you need the cholesterol. There's a lot of stuff is going to go in, and when all of those physiological stars align, that's when you start to see atherosclerosis. That's when you start to see plaque building up. All right, so add an extra 0.114 to that, and there will be a team score. Right now, Team 3 has the Mario star. Right, they're in the lead so far. But as you go through the semester, the teams will be competing. We have to go with the team names. I know there was one team name, maybe a second team name somewhere. And so send me the final team name soon. We'll do some extra credit for the most clever of team names. We already did this one. I'll start to come up with some more case studies soon that we can do. We did this one as well. So I'll come up with some more case studies. But we've exhausted case studies today already, so I wasn't going to put them in here. You know the history stuff. You know the types of risk factors, what we're looking at. The breakdown of risk factors and the stratification of risk group. Those two different ways of approaching people. And blood pressure, probably because it's just so easy to measure. It's just the easiest thing to measure. You can go into a Walgreens and sit there and press the button and it gives you your blood pressure. Every time you go to the doctor's office, they feel like they have to do stuff, right? Doctors feel like they have to measure something, to write something down, so they take your blood pressure. But it sort of doesn't matter on an acute level. If you have a blood pressure cuff at home and you can put it on and just, it's an Omron or something, and you can just pump it up and see what it is throughout the day, throughout the evening, time after time, you're going to know what your blood pressure is. Times when it's elevated, times when it's low. What's it like when you're lying down? What's it like when you're seated? Because at the doctor's office, it's like this. Okay, Courtney, I'll see you now. Like I've been sitting down and like suddenly, I'm like asleep because I'm in the waiting room for 20 minutes, and then suddenly I'm like wide awake, and I sit down and I go, and my heart rate, like my resting heart rate, according to the Fitbit, is like, I don't know, 49. And the hospital might be 110 because I'm like out of breath from just like dozing out. Again, 1 second after sitting down, they have my blood pressure going. And so those numbers really don't mean anything to most people in most circumstances. Blood pressure does mean stuff, but the way it's collected isn't necessarily research grade. And then remember that the heart is a muscle, and the heart needs blood. The heart needs oxygenated blood, and it can't just take more oxygen out of the blood that's there. A little bit. It can take a little bit more oxygen out of the blood that's there, but not much. Skeletal muscle, maybe it's 20%, 25%, something like that. It's taking, it's leaving the rest. The rest just go send it back to the heart. I don't need this. I had my fill. Skeletal muscle takes very little oxygen relative to the heart out of the blood that's just readily available. And then during exercise, you need to get more oxygen to all of your tissues, to all of the metabolically active tissues. You don't need to get more like splanchnic flow to your guts. You can take away from that. But if we have exercise in our history, we're looking at an ability to vasodilate more in the coronary arteries, arteries that supply the heart. And that's how we're going to get more blood flow into the heart, stroke volume, whatever. But vasodilation for the vascular rerouting of blood. But with atherosclerosis, we get a huge reduction in the amount of coronary circulation we have. There are also the lipids, right? So the lipid panel, and then the immune system, right? Go get your white count. Go check what your white count is. It's 4, it's 11, whatever. See what that is. If it's on the high end, that associates more with atherosclerotic development. If it's on the low end, there's other complications, right? You get sick all the time or something. So just remember the way that this goes. We have the LDLs mostly. LDLs get deposited in the intima, and right in here, the LDLs get deposited. And if they can get up and sort of wiggle their way back into circulation and keep moving, that's fine, right? But if they get modified somehow, oxidation usually, if they're modified, then they're going to get really sticky, they're going to stay put, they're not going to get up and move from that point. Now, elevated blood pressure is going to help shove them into that side. Exercise elevates blood pressure, right? But you're going to get this antioxidant effect with exercise. Exercise isn't going to do it. But chronically elevated blood pressure will help deposit LDLs in the intima. If they get oxidized, usually they're going to get really sticky. And then there's going to be a chemokine response. Chemotactic signaling. You're going to have chemical signaling, calling in an immune system response. Macrophages show up. The macrophages come. Macrophages die on those LDLs. And you get this big fluffy foam cell texture. And then they will send up more chemotactic signaling, more chemokine, more chemical signaling. So this is from Nature. Nature is one of the top journals in the world. This is their definition of foam cells. Foam cells are a type of macrophage that localize to fatty deposits on blood vessel walls where they ingest low-density lipoproteins, lipoproteins, everyone say, and become laden with lipids, giving them a foamy appearance. These cells secrete various substances involved in plaque growth, and their death promotes inflammation, thereby contributing to cardiovascular disease. So the chemotactic signaling. We'll talk more about that in the inflammation section. And then smooth muscle comes in, the proliferation phase of smooth muscle, and we're going to get our atherosclerosis here. And then if this cracks, right, if we move around a lot, we go exercise a lot, we do physical activity, and the heart's beating, and we're very pliable in our unpliable bits, we can get a crack in the plaque, in that deposit. And when that happens, it's going to bleed, it leaks, you have to clot, right? You have to plug it up. And if that clot breaks free, we have an embolus. If the embolus lands somewhere, stopping circulation, that's an embolism. And so if you think what a stroke is, that's an embolism. Acute myocardial infarction, right? It's a heart attack, it's an embolism. Skeletal muscle infarction, pulmonary embolism, wherever this thing lands, you're going to have downstream loss of blood flow. Physical activity benefits everything in most people. Benefits lots of components of the cardiovascular profile in lots of people. But excess of physical activity can present limitations, right? It can make a very physically active person look like a sedentary person in terms of their risk profile. So there isn't too much, or there isn't too much. And then some people, just by way of genetics, just by being unlucky, are poor responders to exercise. Not just poor, like they don't get the benefit, they're actually worsened by exercise. So if you look at fasting insulin, these people over here, this is just a ton of people, 700 and whatever people, each little just dot. And these people get a terrible insulin response. Exercise practically makes them diabetic. And that's just, again, a matter of genetics. Plasma triglycerides, some people increase a lot. Resting systolic blood pressure, some people increase a lot. So when the advice is go exercise, do some aerobic activity, and you'll see your systolic pressure fall by 4 to 9 millimeters of mercury. 4 to 9, that's the range that's always reported. Well, that might be a mean value over here somewhere that characterizes these people, but what about them? They get a terrible blood pressure response resting, not just an exaggerated exercise response, so the blood pressure goes up during exercise, but while they're resting. And then these people, their HDL go down with exercise. So any number of cardiovascular risk profile characteristics can be worsened with exercise in a relatively small number of people. But exercisers, that's not a small number of people, right? That's a huge population. And so you're going to be working with a huge population in some capacity. If you do anything clinical, professionally or otherwise, there's a large population. Some people are going to respond poorly. So you give them a bunch of exercise, if you don't monitor anything, if you don't keep track, you risk worsening their health. And remember, this is just for BMI, looking at the amount of US American adults age 20 and over who are obese, call it 40%. And once you hit that's a BMI of 30, but this is for women who have a BMI of 30, there's a 28-fold risk in increasing diabetes, in acquiring diabetes. A BMI of 35, get into that morbid obesity category, and there's almost a 100-fold elevated risk of having diabetes. So obesity and diabetes travel together. Now, a good explanation, not the only explanation, but remember, a good explanation is sugar consumption. The amount of carbohydrate, the amount of sugar that we eat on a daily, if not hourly basis is huge now. It never was before. It's huge now. And we only have about between 4 and 5 grams of sugar in our bloodstream, right? 4 to 5 grams of sugar in our bloodstream. So if you go sit down at a meal and eat 75 grams of sugar, what the hell are you going to do with it? Right? The body's not used to that. And so that's when we see this blood sugar going up. Now that would be in the pre-diabetes zone. If this is a fasted reading, that would be in the pre-diabetes zone. So you eat a bunch of carbs, you get it into the bloodstream, the pancreas notices, there's the pancreas, that thing notices, and you have alpha cells and beta cells in the pancreas. The beta cells release the insulin. The beta cells are like 75%, 80% of them. The alpha cells, which release glucagon, it's like 20% of them or something. There are fewer alpha cells than there are beta cells. So you eat a bunch of carbohydrate, the pancreas notices, squirts out some insulin, and then insulin is going to bind to an insulin receptor, a cell surface receptor. So this is extracellular out here. We're outside of the cell. We have glucose outside of the cell, and we have insulin outside of the cell. Insulin binds to a cell surface receptor, insulin receptor substrate. That's just a protein. PI3K. This is the thing that converts PIP2 to PIP3. Phosphatidylinositol, biphosphate to triphosphate, 2 phosphates to a 3rd phosphate. And that permits PDK to activate PKB, protein kinase B. Once you have PKB activated, arguably PKB is one of the most anabolic enzymes in the body, or an enzyme is just a protein that facilitates chemical reactions. One of the most anabolic enzymes in the body. I can present a strong case that it is the one. But PKB is going to phosphorylate a ton of things. It's going to attach a phosphate to a ton of anabolic things. Among them, AS160, you don't see here, but we're going to mobilize GLUT4. GLUT4 translocation. We're going to take a glucose transporter, GLUT4, up to the surface and bring our glucose into the cell. So insulin signaling, if you're not being physically active, you just rely on your pancreas to get all those carbs. Like you eat 75 grams of carbs and you can't just leave it in the blood. You only have 4 there. And so you got to do something with it. So you kick out this huge dose of insulin and you get this cell signaling cascade. And one of the downstream targets is GLUT4 translocation. Let's get glucose into the cell. Another one downstream from PKB. And here you see PIP2 becoming PIP3, permitting PDK to activate PKB. Glycogen synthase kinase, you are going to deactivate that, which permits glycogen synthase to be active. So all those carbs that come into the cell, you are going to convert into glycogen. So it's a storage. And we'll talk about protein storage later this semester, how it does that with protein. And we'll talk about fat before that. We'll talk about insulin's relationship with fat metabolism, I don't know, at some point, sort of soon. But glycogen synthase, so you mobilize GLUT4, bring carbs into the cell, and then you turn on glycogen synthase to store all of those carbs as glycogen. Okay, what do we know about diabetes? On The Office, Stanley Hudson has type 2 diabetes. That's why he's up there. Yeah, the insulin receptors are for type 2 diabetes. We have these insulin receptors that are just like they've had insulin knocking on the door every day, like every hour of every day for month after month after year, and they're sick of it. Right? They just put the earplugs in. I just can't answer the door again. I can't. Or the phone. Just a scam likely now when insulin comes calling. Scam likely. That's all it says. It just doesn't want to answer that phone call anymore. And we see the exact same thing with alcohol. We see the exact same thing with any drug. Or you see the exact same thing with sugar and your taste. I mean, just don't eat sugar. Don't eat carbs for a while. Eat nothing sweet, and then have a glass of milk. It tastes like sweeter than Kool-Aid. There's a bunch of sugar in it, right? But we get so immune to it because we put sugar, we put sweetener, we put it on everything. That like a peach doesn't taste like a magical, sugar ball in your mouth. we just become sort of immune to all this stuff. But so does your insulin receptor. So there's diabetes insipidus, and there's diabetes mellitus. And in diabetes mellitus, we have type 1 and type 2. Type 2 is like 90, 95% of cases. It depends where you are assessing. It depends on the age of the people you're assessing, right? It depends on athletic history of the people you're assessing. But 90, 95% of diabetes mellitus is type 2. That's the insulin receptors. Type 1 is just the beta cells in the pancreas have sort of thrown in the towel. Okay, who knows who they are? I'm expecting JP to have the answer here. Of all people, for 80s trivia.
So for the people who don't respond well to exercise, the treatment route is medication, or
Yeah. So that's a really good question. So people who respond poorly to exercise, if it's insulin, it's not like if somebody responds poorly to the insulin thing, they also respond, because that's kind of unlikely. People usually have isolated poor responses. But yeah, what is the therapy? Movement without exercise, maybe like non-exercise activity thermogenesis, neat stuff. Be physically active, but don't cross a threshold. Don't overdo it. Kind of a chronic fatigue syndrome, myalgic encephalomyelitis. What do you do with those patients? Because they cross the threshold and they're in bed. And so what do you do with these people? I don't have a good answer, but what I would suggest, which might not be the most scientifically sound or best approach, but would just be let's find a threshold and don't cross it.
combination of that
And medication, and a healthy diet. I think it's more important that they eat healthfully, given that they can't counterbalance poor diet with physical activity. All right, what do we know? First, JP, do you know that?
Two things. One, are they from the Wonder Years?
They're from the Wonder Years?
And then two, I think the kid pictured, there was like a rumor that went around that said that he grew up to be Maryland.
That's true. There's a rumor. It's not true that he is Maryland. No, but there is, but the rumor is true. Yeah, he grew up to be a lawyer in New York, I guess. Like everyone on that show grew up to be somebody. Like, I mean, somebody who's like a contributing member of society. Except maybe Coach Cutlet. I don't know what he did.
Well, there's Ron Howard.
Yeah. JP, what team are you on? You 2.06. Wonder Years. Greatest television program of all time. In my very biased opinion. So, what do we know about metabolic syndrome?
Closely follows type 2. And it's just characterized by coexistence of
Perfect. Coexistence of a ton of pathologies. What's your team? There's a ton of pathologies. 0.04. We are dwindling. 0.114 to 06 to 04. So what we're looking at, and you just need 3 out of the 5 diagnoses. But there's this constellation of problems, and you don't want any of them, and a bunch of them start showing up. They all start showing up simultaneously. So there's genetics at play. If you take 2 people and give them exact same lifestyles, one of them is going to be more at risk. Obesity and insulin resistance, and especially the visceral storage of fat, right? Like the stomach area, visceral storage of fat. Android fat, andro means man, sort of like beer gut, male, android fat, visceral storage. That, obesity, insulin resistance, these really come in a package. Increasing age, metabolism just isn't as much of your friend. A diet, especially a high sugar diet, all these things are going to predict it. High stress, you're gonna get a big cortisol response. Cortisol, you're gonna get more visceral adiposity. But the 5 things, you just need 3 of the 5, is a large waist, high triglycerides, bad HDLs, low HDLs, elevated blood pressure, and then essentially like diabetes, like elevated fasting blood sugar. Technically, this is just pre-diabetes, just means it's elevated. But if you just have 3 of those 5, you're going to start to see a lot of other symptoms showing up soon if you don't You know when there's like warning signs for things, you just can't ignore the warning signs. I guess climate change would be like the whole state burns down every year now. That's a pretty big warning sign. And so it's worth paying attention to and trying to resolve. If you have these things starting to show up, those are warning signs. Those are warning signs that if you allow it to continue, a lot of complications are going to follow. Now, getting back to diabetes, just think of insulin as a vascular toothbrush. You don't go to bed at night with sugar all over your teeth, a lollipop on your teeth and stuff. You brush your teeth, you brush all that stuff off before bed. Insulin, it's like that for the vasculature, right? You get a bunch of sugar in the blood, and insulin is going to come brush it out of the blood. The alpha cells, these, and the beta cells. Notice there are a lot more beta cells than there are alpha cells. You're going to release a lot more insulin. You have a lot more cells to produce insulin. But the pancreas, anything this releases goes straight to the liver. First stop with the liver, and then it goes into systemic circulation. Whatever you put in your mouth and whatever comes out of your pancreas, those go through the liver first and then out into systemic circulation. And then from there, the insulin is going to do its cell signaling. Now, again, there's all the drugs. I'm not going to ask questions about the specific drugs, but metformin. Metformin, does anybody remember how that works? Again, mask. I just heard a word and just started scanning, looking for a moving mouth, and I wasn't going to get one. Okay, so again.
Inhibits the breakdown of AMP, or inhibits AMP deaminase, which breaks down.
Inhibits AMP deaminase, which would break down AMP. 3.039. So normally, right, we go ATP to ADP, ATP hydrolysis, ATP to ADP. And then we take two ADPs and we make one ATP out of it and one AMP out of it, right? Adenylyl kinase reaction. Then we have our AMP, and we got to dispose of that. We have to dispose of our AMP, and that's AMP deaminase. Convert to IMP and ammonia, inosine monophosphate and ammonia. If you block that with something like this, if you block that, you accumulate AMP. AMP binds to AMPK, AMP activated protein kinase, and then AMPK does a lot of things. There's a ton of useful things. Also, sort of abolishes anabolism. AMPK is a big inhibitor of anabolic signaling, but it also does a lot of useful things. So what it will do in its cell signaling, like mitochondrial biogenesis is very helpful, but mobilize GLUT4 in the place of insulin. We don't need insulin, we have AMPK. We're going to mobilize GLUT4 translocation through AMPK. Pancreas, you just sleep, right? You're fine. We don't need our insulin receptors, none of that. We're going to use AMPK to mobilize GLUT4. And then at the same time, we are going to inhibit glycogen synthase. So we're not going to convert any of those carbs into glycogen. And we're going to turn on hexokinase and phosphofructokinase. So those are glycolysis. So we get carbs into the cell with GLUT4. We inhibit their conversion into glycogen. And we turn on glycolysis to burn those carbs. So for diabetes, AMPK is the friendliest thing you'll ever encounter. For anyone who has diabetes, AMPK, that is, it's like a substitute teacher for insulin that's way better than insulin. But the way to get it is to accumulate a bunch of AMP. How do you accumulate a bunch of AMP? Well, exercise does it really well. Go start exercising. You do a bunch of ATP hydrolysis. You're going to chop up a bunch of ATP during exercise. And if you keep exercising, if it's cardiovascular exercise, then you're going to go through that adenylyl kinase reaction. If you keep going, you're going to accumulate a bunch of AMP. Now, with cancer, there's a ton of research that's looking at similar functions of AMPK, of the regulation of cancer, especially prevention of tumors, right? If we're looking at there's a difference in the development of cancer and the metastases, all of these different stages, especially the prevention of cancer. AMPK is like your best friend in the world. Now this one, we're looking at metastases, right? Metastasis, it's not static anymore. after, meta means after, right? So once it used to be static, right? And now, metastatic, metastasizes, right? We're now moving, we're on the march. And so AMPK, these findings suggest that activation of AMPK or restoration of expression may be a potential strategy for prevention of cancer metastasis. So AMPK has a role, once cancer is there, it has a role in preventing cancer. And then it has a role once cancer is there, but it's not always a positive one, not always. And so this one, the AMP activated protein kinase, right, AMPK, is a cellular energy sensor. We'll talk all about it later. But there's a lot of metabolic processes that happen based on the AMP to ATP ratio, AMP and ADP to ATP ratio in terms of human performance, in terms of disease, in terms of recovery. LKB1 is liver kinase B1. It's ubiquitous. It's not like a liver thing. It's all over the place. But early on, we're going to see AMPK acting as a tumor suppressor that protects against cancer. So this is like everyone in the room, I imagine. We have AMPK as a tumor suppressor protecting against cancer. And we talk about somewhere in the study, I don't know if it's on this slide, there, fenformin. It's not exactly metformin, but it's the same class of drugs. That's essentially the same thing. Let's block some AMP deaminase. And so talking about this as a use as fenformin or metformin as a cancer drug might be effective in those patients, but there can be situations in which AMPK is protecting the cancer cells. So it's not just good 100% of the time. It's not just your friend in every situation. It is a friend in most situations for cancer. It is a friend in probably every single diabetes situation. For cancer, it's a pretty reliable AMPK. All right, let's talk about youth, kids, and exercise. Do you have any questions about that stuff? No, we don't. Okay, so kids and exercise. For the longest time, even when I was growing up, people go, "Oh, don't exercise, you're going to stunt your growth," and all these like claims that were being made about development of tissues and the injury risk. And there's just like nobody ever did research on women at first. It was only males, and the excuse was biology. The excuse was, well, when your period comes, what happens to the hormones, and how are your hormones going to interact with the drugs? Turns out we can do research on everyone just fine. And it was just like all sexism. But it sounded like a good excuse. Same thing with kids. You could say something like, well, you're a young boy, your testosterone isn't the same as your elders. And so how are you going to respond to exercise if you have less testosterone? Like the same way everyone else responds to exercise, mTOR. But yeah, all the cell signaling, all the biology still totally works. Like why would little girls who aren't going to have any more testosterone later in life, they have a little tiny bit kind of trouble. Why wouldn't that excuse apply to lady folk at the same time? So people had all these, growth plates are still growing. We don't want to seal those things off. None of that happens though. And so this is from ACSM from 2020, right? March 2020. Big researchers who wrote this. One of the most common myths associated with youth fitness programs is that resistance training is unsafe and harmful to the developing skeleton of children. None of this stuff is true. A well-designed youth resistance training program, there's no scientific evidence that a well-designed program will stunt the growth of children or harm their developing skeleton. In fact, childhood seems to be the best time to participate in strength-building activities that enhance bone mineral content and density. And so study after study, these claims would come out. When was the first marathon run by women in the Olympics? It was like 1980? Somebody Google it. Somebody Google first ever marathon in the Olympics, female. I'll just paste. 1984. Yeah, I was being too generous. Yeah, 1984 was the first ever Olympic marathon run. I mean, the reasons are today sound hysterical. But eventually you do science, oh, your uterus is going to fall out. Or when has that ever once happened? There's a technically hysterical, that's what that would mean. I didn't do that on purpose. But with kids and exercise, these claims kept being made about how horrible it is for kids, and make sure you sit still. And then you just start doing studies, and none of it turns out to be the tiniest bit true. That is from 2009. And what I like about this one is it just got 7 points. This is from the Journal of Strength and Conditioning Research, and it's their position statement. So in 2009, we're going to do some stuff in 2020 here in just a minute. But a decade ago, they said, let's summarize the state of all evidence. We see position stands or position statements. This is a major journal or a major organization publishing the state of the evidence. It's like the State of the Union, right? And they came up with 7 things. Like 8 words or something, it's only really important. A properly designed and supervised resistance training program. And then who cares what it says after that? That's number 1. Number 2, a properly designed and supervised resistance training program can do something good. A properly designed and supervised resistance training program can do something good. A properly designed, you get the repetition. What's important here is that it's properly designed, right? That it's not just treating kids like little adults who have a history of exercise, treating kids like they are invulnerable to shoulder pathology, treating kids like they can't get, they don't have the same structural integrity as somebody who has been training for years, as somebody who's a little bit older, right? So you have to design these things properly. So this is from 2019, and it's youth and skill development. Because sometimes people will say, yeah, but you're gonna get all muscle bound and bulky, and resistance training in kids they're gonna lose the ability to shoot a basketball or throw a baseball. They're gonna become unathletic. They're just gonna get these.
Was there ever a discussion of why kids are playing sports, and like how they compare to relate to training? Because I know it's not considered, I guess, direct resistance training, but there's a lot of different sports that can just flow.
Yeah, I mean, especially something like wrestling. I mean, it's just essentially resistance training beginning to end. But I haven't seen the data about, sort of from the philosophical or sociological perspective of sport motivation, things like that. I haven't seen. But when you look at risk, weightlifting is a really low risk compared to most sport participation. Basketball, soccer, things like this have a much higher risk profile than does weightlifting for kids. So I've seen those statistics, sort of epidemiology of how many hours of participation per predicted injury, and weightlifting is really low on those. But sort of motivations and ethical considerations about kids in sport, I'm unfamiliar with that evidence. So meta-analyses, a meta-analysis, just like metastases, right? It's after something. A meta-analysis, meta means after. A meta-analysis, after all those initial analyses are complete, let's do a new analysis and lump them all in together. Let's just take all of these previous and independent analyses and unite them in a new analysis. So that's what a meta-analysis is. But what they found was, it wasn't like throw a ball, stuff like that. Actually, there was a throw, but it wasn't like, curve balls and some like e-gaming techniques and hand-eye coordination, but it was sprint, squat jump, standing long jump, throw, and vertical jump. Those were the ones that they were looking at, and all of them improved, right? So this, for resistance training and your ability to do X, solve for X, standing long jump. So these are all different studies. And every single one of these little lines over here is a different study. The authors and the years that they are, but standing long jump and resistance training. every single study is showing some positive effects, however meaningful that is. In the standing long jump, there's a summation score. Positive, right? This would be nothing, right? This line right here would mean there is no effect. We begin the resistance training program, we end the resistance training program, they're right where they were, right? Nobody improved at all. That's what this line would be. And it would be weird if that happened with kids, because kids are continuing to age. If it's a 10-year-old, if it's a 12-year-old, if it's a 10-year-old and, you know, like 6 months go by, if it's like a 6-month training program for a 10-year-old, I mean, that's like a 20th of their entire life just happened. The maturation should show improvement. And we'll talk about that in just a minute. But standing long jump, yeah, everything was good. Sprint, this one they got slower. That's one study. And here's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 studies they got faster, and one study they got slower. Now, it depends on how they do these analyses, the types of kids that they recruit, the conditions of the experiment, the duration of the experiment, how they do testing. But sprint, overall, they analyze everybody, lump them into, and analyze everybody. There's improvement. Same thing with squat jump, same thing with the throw, same thing with vertical jump. There's just improvement in everything in response to resistance training with kids. This is another 2021. The effects of resistance training on physical fitness in healthy children and adolescents. And physical fitness, it depends what you mean by that. You know, athletic enhancement, stuff like that. It's not always just heart health. And so what they were looking at was muscle strength, muscle power, again, a bunch of different studies. We're in meta-analyses here. Muscle strength, muscle power, linear speed, agility, throw, sport-specific performance. There's just one study for sport-specific performance, but same thing. This would be no finding. This side of that line would mean resistance training ruined you. You somehow got a little bit worse, your performance deteriorated. This side of that line, everything is on this side of the line. Everything is showing improvement. And so the mean value and then some standard deviation assessment. Confidence interval, I guess it is just like standard deviation. So 95% confidence interval. And so in all of these components, so I have muscle power, muscle strength, linear speed, agility, throw, and sport-specific performance. So even like the sport-specific performance stuff, I mean, if you go try to shoot free throws right after you finish an upper body workout, you're not going to make it. I don't care if you're LeBron James. If you just finished like an arm workout for an hour, you go try to shoot a free throw, you're not even going to hit rim or backboard. It's just like, it's sad. But like recover for a minute, right? Just go back tomorrow and you'll be fine. And resistance training, we're seeing improvements in a lot of these things. Another meta-analysis, this was from 2018. So there was this period where everybody was researching kids because there was an absence of children from the literature for a long time. And then there's a big explosion of kidlit, of let's all evaluate kids and exercise because people are making claims and those claims aren't backed by evidence. So let's put some evidence forward. And then the age of meta-analyses, which is now, which is just over and over and over, looking at these meta-analyses from slightly different perspectives. So this one is, so this one is looking at what you should do. How do you prescribe it? What kind of exercise is going to elicit an improvement in the kids? What kind of rep range? How many sets should they be doing? What level of intensity should they be doing? And so the prescription of resistance training for kids, that's what this one is looking at. And there's a couple of different things. They're basically both jumps. There's a CMJ and the SJ. So I think this is a squat jump and the CMJ. What does that stand for? Something jump. Counter movement. Nice. Yeah. I think that's what it is. Counter movement. What is that? What does one do? Okay.
Counter movement.
Okay. Then what would the squat jump compared to that be? The SJ was a squat jump. Okay, all right.
Continuous,
Two different jumps. Pardon?
continuous movement.
Continuous
No,
movement.
counter movement.
Oh, counter. Okay. So counter movement and a squat jump. So they're both jumps. But specificity of adaptation, depending on how you train, depending on the movement profile, the speed, you're going to improve in specific ways. So what they found in this was training over 8 weeks, that's helpful. Training over 8 weeks is more helpful. You get too high in intensity and they're not seeing as much improvement. Moderate too high. Too light and you're not going to get anything either. But moderate intensity, and you can edge in on the high intensity, but don't go all in with kids. So moderate to high, that's a good place to be. And the amount, this 95% confidence interval, that's the amount of improvement that they're getting. Again, with training, it should be over 8 weeks, moderate to high intensity, but not high. And then they improved for this one twice weekly or thrice, 3 times a week. They improved with both of them. There's a little bit more improvement with the 3 times a week, but this is only one of the jumps. And then number of repetitions per set, you should get elevated a little bit. It's a little bit like at 5, there was an improvement. And at 11 and 12, there was an improvement. So it depends on how they're doing things. It depends on what 5 means. This is 5 RM, this is 12 RM. So this one I'm a little bit less interested in. And then on the other one is sort of the same thing. We're using the moderate to the high was the best. That was the best improvement, was moderate to high. 2 or 3 times a week, both of them worked. Greater than 8 weeks, that was the most improvement. So what they said at the end was, whatever, you have a couple of kinds of jumps. Moderate to high in those ranges. That's where you're gonna see most improvement for the intensity working with kids. Get in that moderate space, moderate to high. Make sure it's over 8 weeks. Don't do these like 2-week training programs. 2 to 3 times a week training. More than that, it's not going to be helpful. 1 day a week, you can do more. Number of sets and number of repetitions. Certainly the number of repetitions, it's a single study did it, and I'm just not that interested. But the number of sets, they're going to have diminishing returns after the 3rd. For somebody who's like 25 years old and has been training for a decade, 3 sets is probably insufficient. For somebody who's 12 years old, 13 years old, 3 sets. That's it. I wouldn't go over 3. Diminishing returns and an increased risk of stress that they're going to have. So for this one, this is a year, I just 2020 or something like that. But they talk about like during the 70s and 80s, people were interested in, the researchers and scientific societies postulated an increased risk of sustaining injuries when conducting resistance training because of the immaturity of the skeletal system. In addition, it was argued that resistance training in youth is ineffective due to a lack of circulating anabolic hormones. Okay, so these initial responses, but since then, compelling evidence of resistance training and/or plyometric improves muscular fitness, bone mineral density, body composition, motor performance, and lipid profiles. I mean, just name a thing that can be a component of health that can be used to say, I'm healthy in this thing. And kids are improving with that. So this one is from the American Academy of Pediatrics. And they talk about how it's critical now, as we look at disuse atrophy, as we look at activity patterns in youth, recess, I go to stand there and whatever, pick flowers, and we're looking at athleticism that's worse with each successive generation in youth. The American Academy of Pediatrics is encouraging resistance training. And they talk about the resistance training risks, and here's where they're talking about injury risk relative to other sports. It's low. is lower than those in other sports, or at recess. Go just on recess, and the likelihood of injury is higher than if you go to the weight room instead of going to recess. So this idea that kids are going to get injured doing it, but again, supervised, well-designed, technique-driven resistance training program. Not like go pick up the heavy dumbbells and see what you can do with it. That's not helpful. But resistance training risk is very little. Overtraining is sort of depends. Again, design it well. Make sure the kids, couple of days a week, no more than a few sets, moderate to high intensity. Don't overdo any particular muscle group, and you're not going to wind up with overuse injuries. But it's something to be very mindful of, because overuse is really what we do in life. We pick a thing and we just exploit it. Like how do people watch Netflix? Netflix dumps a season at a time. Does anybody watch it one episode a week? We binge everything. Like there's nothing, if it's something that we want or something that we like doing or something that we think we need to do, we binge it. Same thing with studying. People binge studying, like the day before the test. They binge Netflix, they binge the dinner table. We binge stuff. We have to be really cautious with kids not to binge them into exercise. And again, skeletal risks, there really aren't any. It's actually good for the skeleton if it's done right. So this is how they end theirs. Misconceptions. A child is unable to increase strength before puberty. Nah, they can increase strength. Young boys and girls may get muscle bound if they resistance train. Nah, just stretch a little and move, and that's you're not going to have that problem. Resistance training may decrease aerobic performance in youth. Resistance training may stunt growth. Children are stronger now than they ever were before. No, not even close. 1 RM testing, maximum testing is unsafe for youth. Not even really that. Not even, because we think of like 1 RM testing, how strong are you at your max? And that isn't even particularly risky for children. So resistance training is not risky. It helps develop their skeletons, increases motor performance, and they'll control for maturation. Right? I just have a control group. It's easy to do. Have one group doing resistance training and one group doing nothing, and see who improves. Often, if you go from 12 to 13, you'll probably improve just from aging, maturation. But you're not going to improve nearly as much as the resistance training group. So the last thought to leave you with is that what I've just been saying if this little kid wants to be a pitcher, it's like dreaming of being a pitcher, and so he sees high school pitchers, he sees college pitchers, he sees professional pitchers, what they do for training. They go on the mound and they practice 80 pitches or something. And so he thinks he can go out in the yard and throw 80 times. No, you don't have the background for that, right? You don't have the integrity in your sinews and your tissues to be able to withstand those forces. We have to monitor kids. We can't just, if you leave them to their own devices, their ADD will be crazy and they'll do like 1 rep of everything, and that's fine. If we give them an exercise structure and that structure is inappropriate, or we don't monitor that structure, at that point it can be risky for kids. But that's really the only situation. Everything else is positive. All right, we're done with kids. Does anybody have any questions? Because like we're all adults here, so let's talk about adults from now on. But does anybody have any questions about working with kids?
Isn't there like kids with their recovery being like sometimes not doing
That
adult?
is a good question.
One.
5, 9. Yeah, so recovery is going to be different, and there are some differences in maybe inflammatory profile and what happens in their blood in response to exercise. But recovery is likely to be faster depending on things like sleep, depending on things like nutrition, depending on lots of variables. I don't know. I'm not familiar with the data of how fast recovery might be expected, but when do they return to peak performance? It's a really good question. That's all I have. It's hard to come back after what for me was like Saturday, Sunday, Monday, Tuesday. Yeah, it's hard to have any energy. Pardon?
Are you putting Palmer's numbers?
Oh,
It doesn't say like